Hi guys, Dr. Gillard here. It is week 8. It's the spring of 2021. Important lecture today on basal cell carcinoma and Melanonychia, a word you probably never heard before. So off we go. Basal cell carcinoma first. This is by far the most common type of skin cancer. In fact, it's more common than all the other types of cancer combined. Now, it usually doesn't metastasize like malignant melanoma does, but it's incredibly destructive. It's a very invasive cancer. It can get into the facial bones, into the nerves, into the brain. For whatever reason, it's not great at getting into the blood vessels and metastasizing, though, which is kind of strange about it. And then it's hard to get rid of. It tends to come back after you have it removed. What does it look like when we'll look at plenty of pictures of this, but what is the general presentation of this cancer? It usually starts out as a erythemic, which means red papule or plaque. So kind of a raised lesion, maybe a centimeter, maybe less, maybe a little bigger. Sometimes it doesn't always have to be red. Sometimes it's skin colored as well. Sometimes it has characteristic rolled borders. They can be pearly white sometimes, which we'll look at pictures of that. You can see little pearls here. There's a little pearl there and pearl there. So it's kind of got a raised border, pearly white lesion. And then one of the classic signs is it ulcerates. With the passage of time, it starts to get a little kind of hole in it and it starts bleeding. And then it scabs over and it bleeds again, and scabs and bleeds. So it can have a crust on it when you see it. Maybe it's just been bleeding and it doesn't have a crust or scab on it. And these can get very destructive and very huge, and not a good thing. We'll see some gross pictures here, I'll warn you right now. Yeah, now why would someone let it go this long? You know, who knows? You got to get these things when they're like this, right? Get them out because they can take over your whole face, and yeah, got to catch these things early. Interestingly, there has been a 10% increase per year in the incidence of basal cell carcinoma. Possibly the thinning ozone has something to do with it. We're not sure. It's a very complicated cancer histologically speaking. There's over 26 different subtypes that have been reported. Authors agree on 7 major types, but really there's about 3 that the books I use agree upon, and we'll take a look at those in a minute. And another weird thing about it, although sun exposure is definitely a risk, it's the #1 risk factor. This cancer, about a third of these cancers occur in places that doesn't get much sun. So it can occur in areas that don't get heavy sun exposure, like the medial canthus of the eye. Kind of this part in here is usually shaded by the eyebrow. There's one starting. You can see it's got a little lesion and you got the little pearly white dots around it. And then behind the ears, and it can occur. So that's interesting about it. It typically strikes in people over 40. About 85% of the time it's somewhere on the head or neck. The nose is the most common target of it. Again, why do people let it go so long? I don't know. But they do, and then we get these terrible pictures. All skin cancers, if you're red-haired, lots of freckles, green, blue eyes, you're at risk. You should not be a sun worshiper for sure. African Americans rarely get this type of cancer. They do get other types, but not this one, possibly because they're protected by so much melanin. And yeah, and UV radiation is still a main risk factor, as we said. Just some fun facts, risky areas. So they can show up on skin that's been burned, especially if it gets exposed to sun. Now, I'm not talking about a sunburn. I'm talking about, like a burn from hot water or from fire or something like that. Those areas are more at risk for developing this type of cancer. Areas that have been scraped, like you fall off your bike and you get road rash and you get a little scar from that. Those areas are more susceptible. And it's hard to get rid of. Once you've had this cancer, there's a tenfold risk that it will reoccur after it's been cut out the first time within 3 years. What's the pathophysiology behind basal cell carcinoma? Well, just as the name as the name sounds, it's a mutation of basal cells. Basal cell carcinoma, it's a mutation within basal cells. You guys will remember that basal cells live in the stratum basale, that's the bottom layer of the epidermis, and those are stem cells. They give rise to all the cells that come out of your skin, including the keratinocytes. And I won't go down that rabbit hole. I have videos on that if there's other YouTube people watching this. My students already know what this is. And so basal cell develops a mutation, and just like all cancer, cells don't live forever. They're supposed to have programmed death. These cells don't. Their apoptotic mechanisms are turned off, and they become immortal. They become mutated, and they start growing, and they take over the epidermis. They go down into the dermis and even into the hypodermis, and they can get into the bone and the muscle. It's just a very aggressive type tumor. But as I said, strangely, it doesn't do very good at penetrating into blood vessels. The tunica adventitious stops it, the tunica media stops it, and the endothelium all seem to be resistant to these cancer cells. So that's something probably is a good thing. Unlike malignant melanoma, which is very good at penetrating the tunics and getting into the bloodstream or getting into the lymph system. A little deeper with pathophysiology, it's thought that the UV radiation wipes out a tumor suppressor gene within these basal cells, specifically the patch, PTCH suppressor gene. I just call it the patch. It looks like patch to me, PTCH patch, even though there's no A in it. Or whatever you want to call it, PTCH gene. And yeah, tumor suppressors catch mutated cells and they destroy themselves. And yeah, if you don't have that working, there's nothing to stop the mutated cell from spreading or replicating. There are 4 types of basal cell carcinoma. The authors are all over the place on this, but the 3 big books that I like, Fitzpatrick, Bologna, and Rook, they all agree on 3 of them: nodular basal cell carcinoma, superficial basal cell carcinoma, and morphiform, also called sclerosing basal cell carcinoma. Fitzpatrick puts another one in there called pigmented basal cell carcinoma. The other authors don't. And if you go into the research, there's over 20 different types. You can go way into the weeds on this. So we're just kind of scratching the surface. But nodular and superficial, we'll talk about a little bit here. So nodular, look at it, very aggressive. See what I mean? Just basically ate a chunk of his ear away. Again, why don't they go into the doctor? I don't know the answer to that question. But the nodular form is the most common type. About 50% of basal cell carcinomas are nodular type. Again, they're not metastatic, very aggressive. I mean, they can cause, all cancer can cause metastasis. Basal cell carcinoma can definitely get into the bloodstream and spread to the liver and brain, but it's not very good at it. It's not like basal cell or even squamous cell carcinoma. But it is very destructive, as you can see. The nodular type isn't as destructive as the superficial type, so that's at least one good thing with regard to aggressiveness. But it is incredibly destructive. It may be slow, but it rips tissue to pieces. So got to catch these early, right? This is the one that starts usually with the pearly white lesions that we've been looking at. They're papules or nodules. They can become telangiectatic, which means they can be filled with blood vessels. If you ever see blood vessels within a growing lesion, that means the cells are growing very fast. They're probably cancer cells. Not always, but that has to be checked by a dermatologist. These also have the pearly white rolled borders. And these can definitely ulcerate and bleed and crust with the passage of time. And there's another one, a really beautiful one, not beautiful, but a really nice example of one. See the pearly white borders here around the outside, and it's crusted over. It's been oozing and bleeding and oozing, kind of a cycle there. So classic nodular basal cell carcinoma. Let's see, what else do we need to know about it? As it grows radially, It can become very telangiectatic. I guess we're going to show you a picture of this. So yeah, there's a classic it's a nodule, right? It looks like a nodule, and you can see it's even the skin around it has become telangiectatic. There's no doubt if you start taking this off, you'll find it out in this area as well. But that's the indication of a fast-growing lesion, and those have to be looked at quickly by a dermatologist and most likely taken off. And yeah, they can. With time, this can develop an ulcer here and start bleeding. We're kind of past the pearly white border stage. There's another one. You can see the pearly whites, little pearls here on the outside. Can't tell, maybe it's been oozing a little bit here in the middle. But classic basal cell carcinoma. I've known 2 students so far who have had this type of lesion on their skin since I've been at the school over 6 years. There's been 3 skin cancers, 1 melanoma, and 2 basal cell carcinomas. Just from the students just coming to say, can you look at this lesion? I say, go to the dermatologist, and sure enough. Catch it early, you'll be fine with these things. We're not going to go down the weeds with superficial basal cell carcinoma. Looks kind of innocent though, doesn't it? It's just a red patch. You think, oh, I must have scratched myself, or it's abrasion of some kind, but it doesn't go away. It stays there. So if you ever see something like that, very erythemic, maybe a little crusty, there's not much white pearly border around it, but that's superficial. It's not as common as the nodular type though. The treatment to these things is you gotta get rid of them. You gotta cut them out. Radiation, I mean, if they're giant, if they're too big to cut out, if you waited too long, they could try radiation therapy on them. But yeah, unfortunately, these are very destructive and very invasive, so oftentimes it's a big procedure and very wide margins are taken. A lot of the good tissue has to be taken until you finally find tissue that's cleared. You have to biopsy sentinel nodes around the area as well. Look at these recurrent rates. So 5-year recurrent rates. So for basal cell carcinoma on the neck or trunk or extremities, about 8% will grow back within 5 years. If it's on the scalp or head or temples, 13%. The worst is on the nose, eyelids, chin, the jaws, the mandible, and the ear. Getting close to 20% reoccurrence rate within 5 years. So very tough to get rid of this cancer. That's why they have to take such wide margins. All right, let's start the nail now. We got to do a little anatomy here so you understand a little bit about the nail. So the nail has some parts to it, of course. All the parts of the nail is called the nail apparatus or the nail unit. Nails are only found in really primates, so humans, monkeys, chimps, etc. are the only things that have nails. There's 3 main parts. There is the nail plate, the nail bed, and the nail matrix. And their surrounding tissue is kind of important. We'll look at the fold, the proximal fold, and is important as well. What does it do? What does the nail do? Well, you have a delicate little phalanx underneath, a distal phalanx. So its job is to protect the distal. What's the plural of phalanx? Not phalanxes, phalanges. Protect the distal phalanges. Okay. So yeah, here's the nail. This is the nail plate. It's just commonly called the nail, but it's a double layer of cells we'll look at in a second, but it's called the nail plate. Underneath it, there's a nail bed, and that is, underneath that, there is a dermis layer, and underneath that, this is the dermis, underneath that, there's bone. See something wrong or see something weird about this? Where's the subcutaneous tissue? Where's the hypodermis? There's none. It's missing that big thick layer. So that's why this is kind of delicate here, but I'll try to stay on my slides here. Okay, so we have a nail plate. It's made up of not keratinocytes, like the skin is made up of keratinocytes, but it's made of a similar type creature called onychocytes. And the proximal part of the nail plate, so the part closer to your elbow, that rests and covers something very important called the matrix. There's a proximal and distal matrix which lives underneath the proximal part of the nail plate and the proximal nail fold. That's protected. Sometimes there's a little white kind of like a crescent that you can see at the proximal part of the nail plate. That's called the lanula. Lanula. Let's see the lanula. Right there's the lanula. This is the proximal nail plate. This is the distal nail plate. Here's the distal fold is right here. Or I'm sorry, the proximal fold. If we go down deep, the matrix would be right underneath here. Very, very important. That's where the cells come from. All right. What else? Nail plate rests on the nail bed. I showed you that. Proximal nail fold covers the proximal nail matrix and part of the distal nail matrix. Here is looks like a gorilla's hand, but just to show you, yeah, they have thumbs. They have a nail plate just like we do. Right? Just another picture to show this big proximal fold here. The cuticle, you can see if you look carefully, unless you've had a manicure, you can sometimes see a little tissue that's stuck to the lanula. That's there for a reason. That's not supposed to be scraped off. Manicures are not good at that. Well, I mean, that's people do it all the time, but that cuticle is supposed to be there to protect the lanula. Lanula is a very delicate. Those are very young nail cells. They're onychocytes, and that's made. That little cuticle is made to protect that region. So don't scrape it off. There's the nail bed, proximal nail fold. There's the proximal matrix. There's the distal matrix. This is where the magic cells are. We'll look at here in a second. So how do you make a nail plate? Because we know that if you're playing with your nail and you feel your nail, those are tiny cells. It's a double layer of cells called onychocytes. And they're born in the matrix. So right in this region here is where they're born. I got a nice picture coming up to show you that. It's a double layer. So the proximal, I've asked this question before, not very often, but the proximal matrix produces the dorsal nail plate. That's the one you're maybe fooling around with right now. The ventral nail plate is produced by the distal matrix. All right, so here's a very cool picture. And there's the proximal matrix here. And there's little basal cells here cranking out new onychocytes. And it's pushing them forward as they divide through mitosis, just like the epidermis does. The epidermis pushes up though, right? The cells go up this way. These cells are pushed forward into a nail plate. And there's the distal nail matrix, and those create the bottom layer of these onychocytes. So double layered. All right, what if you damage the matrix? What if you damage, let's see, is my pointer working? Yeah. What if you damage this? Somebody steps on you, smash your hand in the car door, and this turns all black and blue. Maybe you have to go to the ER and have them poke a hole in it to have it drained. Shouldn't probably use a safety pin. People, remember I had one of these back in the day. My dad was a physician. He heated up a paper clip and he poked a hole in it with a paper clip, and the blood and came squirting out of it, and it felt good. I don't recommend that though. I'd go get that done because you could get infected. You damage this part of the nail, you'll be fine. It'll take a while to grow back. We'll see the speed is very slow. You damage this part of the nail, it may never grow back because this is where the matrix is. And if you damage the matrix, you damage the stem cells. You can't make the onychocytes. Right? So that's a bad place to damage. All right. Birth of the nail plate. So these onychocytic stem cells, they're like basal cells. I shouldn't have called them basal cells because these basal cells live in the stratum basale of the epidermis, the bottom layer of the skin, bottom layer of the epidermis. They just call them onychocytic stem cells. Give rise to onychocytes. That makes sense. By mitosis, and they divide by mitosis, and the cells are pushed forward as I as I showed you. Yeah, newly born onychocytes are pushed forward, parallel to the plate, double layered. Right? There's that same thing, how they're born here, magic happens here, cells are divided and they're ratcheted forward. The new cell forms, it pushes the old cell forward. Another cell forms, it pushes those two cells forward, etc., and etc., and you get a nail plate from the matrix. What's the speed of growth? It's pretty slow. It's 1 to 3 millimeters per week. So toenails are 1 millimeter. Fingernails are a little faster, at 3 millimeters per week on average. So therefore, if you do the math, it takes about between 12 and 18 months to actually replace a nail that's been ripped off. Maybe you snagged it on something, or you're playing basketball and you hit the basketball the wrong way and it ripped your nail off. Yeah, so it can grow back as long as you don't damage the matrix. And the older you get, the circulation slows down, and the nail growth slows even slower than that. All right, keratin. So what makes our nails so hard? Well, keratin. The skin is filled with keratin, but it's a different type of keratin. The skin is a soft keratin, but the nail is a hard keratin. So in fact, the nails are about 85% hard keratin, and they are the rest of it is soft keratin. The keratinocytes of your skin is pure soft keratin. It doesn't have hard keratin to any significant amount, to my knowledge. Nail apparatus versus distal phalanges. What's the function of this nail plate? We already said it protects the distal phalanges, because why does it need protection? The rest of your body doesn't need protection because there's no hypodermis. There's no third layer of skin there. So it's weak and it needs some protection. Plus the distal phalanges are tiny. Remember seeing those in lab? They're tiny little things, and they're delicate, so they need some extra protection. So what is that? What's the big deal with that? Well, this is because there's no hypodermis. If you get an infection in your nail, it could easily spread into the bone. So you could get an osteomyelitis because you're missing that big, thick hypodermis layer. And vice versa, if you have a inflammatory autoimmune type disease like psoriatic arthritis, you have an inflammation in your bone, the inflammation can spread up into the nail, into the matrix, and start making a weird looking nail. So you can get disease spreading from skin into bone, and from bone into skin, mainly the nail. Okay? Yeah, because there's no subcutaneous tissue. We said that. Everything I just said. You pull a hangnail, it gets infected. That's why your mom always yelled at you when you're little. Don't pull your hangnails. You'll get an infection. Well, she was right about that, because you get an infection in your nail, and it's much easier to get in your bone compared to any other place in the body. You don't want to get osteomyelitis. Here's a patient with psoriatic arthritis. The classic little link sausage fingers here, and the psoriatic arthritis from the bone spread into the fingers and inflamed the fingers and destroyed the nails. So that's just an example of that. Little radiology. You know I love my radiology. Since we're talking about psoriatic arthritis, the classic board question. It's actually kind of a rare finding, but for whatever reason, even back when I was in school, they love pencil in a cup psoriatic arthritis, where the inner phalanx right here, the intermediate phalanx, is eroded into a point. See how that's kind of a point? And then the proximal distal phalanx has expanded out. So you get this is called the pencil in a cup. And that's classic of psoriatic arthritis, right? Pencil in a cup. There's another picture of it. Okay, little radiology today. There's someone with psoriatic arthritis, pencil in a cup underneath, and look at the nails, how mutated they are. They get this classic pitting of the nails. It's kind of the chewed nail appearance. There's an oil drop sign. I took a lot of these slides out because this is not radiology class, but Yeah, just the case in point is patients with psoriatic arthritis can get malformations of the nail as well. Okay, so what's underneath the nail plate? We said the dermis is underneath the nail plate. Did we say that? Underneath the nail bed. We didn't say underneath the nail plate. That's a modified epidermis we'll look at in a minute. But underneath the nail, the dermis under the nail bed, yes. Because the nail plate is top, then the nail bed. Underneath the nail bed comes the dermis, and that's filled with blood vessels. We've looked at that already. And the weird thing is about the dermis, it connects directly to the periosteum of the phalanges, of the bones, the finger bones, which is weird. Again, there's no third layer down. There's no hypodermis, right? So plate, nail plate, nail bed is underneath that. That's a kind of a modified epidermis. And then we have the dermis here, right? The nail bed, as I just said, it's a modified epidermis made of modified stratified squamous. It's not keratinized though, and specifically there's only two layers. There's a stem cell layer, the stratum basale, and then there's the next layer up is stratum spinosum, but we're missing the granulosum, the germinativum, stratum corneum. They're all missing. So this is even thinner than the esophagus is 3 layers, which is weird. This is only 2 layers. So the nail bed, though, is made up of modified stratified squamous epithelium. And it's only 2 layers thick. That's where the modified comes from. And, yep, beneath that is the dermis. And then again, the third time, there's no subcutaneous tissue. Let's talk about these matrix melanocytes. So just like in the stratum basale of the skin, we talked about these little octopuses, how they inject the newly born keratinocytes with their little tentacles, and they inject melanin, which goes and covers the nucleus to prevent solar damage, and it gives the cell some color. Look at the color of your skin. The darker your skin is, the more active the melanocytes have been. Those keratinocytes are all filled with melanin. You ever seen someone with vitiligo where they have a white spot? That's an area where there's no melanocytes and there's no melanin. Or an albino who has no melanocytes anywhere that don't work, so they don't have any melanin in their skin. So what's the deal in the nails? Are there melanocytes in the nail matrix? There are. They live just like they do in the stratum basale. There are melanocytes that live in the matrices of the nail. But here's the key. Normally, they don't do anything. They're just hanging out. They have the potential to wake up and inject melanin, but they normally don't. That's why if you look at your nails are, all humans' nails are the same color. No matter what your skin color is, your nails are always that little pinkish color, unless something's going wrong, which of course we're going to talk about. Okay, so there are melanocytes, but they don't work. They're dormant normally. So case in point, here's a piece of skin like your back of your hand. We have a melanocyte here in the stratum basale. It's injecting, it's doing its job. It's sticking its little tentacles in all these brand new fresh-born keratinocytes, and it's forming a nuclear cap. And that cap gives your skin a brown color. The more melanin, the browner your skin is. You go out in the sun, start getting a suntan, what happens? These melanocytes get very excited and they over-inject the cells, and that makes you brown. Now here's the same melanocyte, the matrix melanocyte, in the matrix of the nail, and they're there, but they don't do anything. There's no melanin. The octopus little tentacles are flapping around, but nothing's happening. Got it? All right. Now, so then that begs the question, what happens if they wake up? What if they wake up? One of them wakes up and says, oh, I'm going to get rid of this melanin I have. I'm going to start injecting it. And that does happen. That's called, there's a word for that. That's called Melanocytic activation. Melanocytic activation is when our little melanocyte wakes up. If this is the nail and one melanocyte wakes up, he's activated. Melanocytic activation. They're all activated in the skin, but if that happens in the nail, it's going to do something weird, isn't it? What is it going to do? Well, all of those onychocytes are going to be pigmented. But you only have one or two, maybe three melanocytes woke up, so you're going to have just one little narrow band of nail color. And so you get these little narrow brown or black streaks in your nail. And those streaks are called melanonychia. Melanonychia. Got it? So here is melanonychia. So for whatever reason, a little group of melanocytes woke up and they said, hey, let's inject these onychocytes. And they say, well, we don't want to be injected. Well, too bad, we're going to inject you. And so they get injected, and remember how they're born. Here, this one was injected. Another one would be here. Another one would be here, 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 here. Pretty soon, there's a streak is all the way down your. It doesn't just all of a sudden pop up like this. It starts out here, and it grows a couple millimeters a week until it goes all the way out. So right down here in the matrix, you have activated melanocytes for whatever reason. This is called melanonychia. And it's got some AKs, of course. Well, we'll talk about functional. That's got to do with what's causing this. But sometimes it's called longitudinal melanonychia or matrix melanonychia. Right? Functional is interesting. There's functional means we know what's happening here and it's not dangerous. So let's get into that. Functional melanonychia. Sometimes the melanocytic activation is called functional melanocytic activation. And I know this is going to get a little confusing here. I actually rearranged my cells, rearranged my slides to try to make this more understandable. But there's melanonychia. And we've talked about this a little bit, right? When we talked about subungual melanoma, Bob Marley killed him. You see the cuticles here? You can see the cuticles covering the lanula. Those are good. They may not look so good, but that's good and protective. And here's just another example. So here's a cartoon of sleeping melanocytes, the blue ones, and these two woke up. And every time the stratum or the stem cells give rise to a new onychocyte, it gets injected, and then it just pushes forward, and you got this cool-looking brown streak in your nail, which is super, super common. People of color, super common, as we will see. All right. Melanocytic activation, just another picture. This one's a little more concerning though, right? Some of you are going, ooh, I don't like the looks of that. And I don't like the looks of that. It's too wide and it's in the proximal nail fold. That's a Hutchinson sign, right? That could be cancer. That one needs to be checked out immediately. But so the point of this slide is it's still melanonychia. We didn't mention what the cause was, because it could be functional, it could be hypertrophic, and we'll look at those different types, but still melanonychia. This is very wide looking though, so some call this a wide longitudinal melanonychia, but I don't like that, and we'll expand on that in a minute. The streaks can be thin, they can be thick, they can be variegated. These are not good signs either. If it's variegated, that means it's mixed colors. They can take over the entire nail plate. That's not good. There's another one, an African American. Yeah, run-of-the-mill melanonychia. From melanocytic activation, the question is, what has woken up the melanocytes? So, the word functional comes in here. We should talk about. Functional means it's no big deal. We know why we have an idea why. And there's the key is the density of melanocytes, the number of melanocytes in the matrix is unchanged. You just have basically woken up some melanocytes and they're working. You don't have them proliferating. So that means functional. It's no big deal, right? So there's a many known causes of getting a nail streak. So people who are pregnant, all the hormones can cause it. People who are nail biters or have manicures frequently, other nail injuries, stepped on your toe playing softball, jammed your nail playing basketball, wearing tight shoes. You can get these things from trauma. It irritates the matrix, and the matrix, some of those matrix melanocytes wake up. Psoriasis, Addison's disease, HIV. You guys need to know this. I'll tell you right now, if this one's coming on the test, I'm always going to pick some of these, because you're going to have patients show you their fingers and it goes, oh my God, I got cancer in my finger. What is that? And maybe they're pregnant, or maybe they're on chemotherapy or having radiation treatment. Maybe they're just getting older. Older people have these. Onychomycosis, they're common in that fungus of the nail. And then sometimes we don't know why they start, but they do a biopsy and it's the number of melanocytes is the same. Right? People of color, these are very, very common. This is well known. People who have darkly pigmented skin have a much greater chance of developing functional melanonychia. Their matrix melanocytes just like to wake up. African Americans, about over 90% of them have had one of these or have one of these right now. So they're super, super common. I've had tons of students who have had these and they're no big deal. Right, there's another one, African American male. Another one, I think we looked at that one already. All right, now there is another cause of melanonychia. So this time, when you do the biopsy, you have too many melanocytes as the problem. So these fall under the category of melanocytic hyperplasia. Melanocytic hyperplasia. And there's two types of melanocytic hyperplasia. One is no big deal. That's benign melanocytic hyperplasia. One is a very, very big deal, and that's malignant melanoma. And we've talked about that before. So let's talk about benign melanocytic hyperplasia. So this was the second category. Remember, we had functional melanonychia, and now we have melanocytic hyperplasia. It still creates melanonychia. Functional melanonychia creates a line in your nail. That's melanonychia. Melanocytic hyperplasia still creates a line in your nail. So these both are causes. I know it's kind of confusing the way they categorize these, but they both create lines in your nails, and that's melanonychia. So this is when there's too many melanocytes, as we said. So hyperplasia has occurred for whatever reason in the matrices. So the birth rate of melanocytes has been increased by something. Maybe something not too sinister, maybe something very sinister. So let's look at the types. So there's two causes of benign melanocytic plasia. These are very, very common. I see these, I get emails on these, get YouTube messages on these things. But sometimes you have to biopsy them to make the diagnosis, because you can't tell just by looking at it. But benign melanocytic hyperplasia. Lentigo we've already talked about, right? Super common. We've talked more about solar lentigo. We didn't go into the weeds on it, but there's many types of lentigo. But it's just little brown oval patches that pop up, especially with aging. They're flat. They're not affected by the skin. Remember the FEDs, the freckles. The difference between a freckle and a lentigo or lesion is the sun. The sun will darken a freckle. A lentigo lesion doesn't have any effect on it. You can get these same lentigo lesions in your nail matrix. And the lesion is characterized by an overgrowth of melanocytes that stay in a little ball. They don't go into a nest, though. This is a mole, a nevi, or nevus, a singular. They're also groups of melanocytes but they're precursors. They're melanoblasts that grow into a nest. Melanocytes are mature, normal melanocytes that have just grouped into a little ball and have all been activated. And then we have malignant melanocytic hyperplasia. That's cancer. Maybe precancer. You might catch it before it turns cancerous. But subungual melanoma was an AKA for malignant melanocytic hyperplasia, which was under another category. I know, it's confusing. What can I tell you? It's the way, the way this stuff is. Remember the stomach gastritis is, oh my gosh, that was so confusing. Anyway, subungual melanoma is under the category of arcuolentiginous melanoma. Guys just got tested on that. So let's look at the benign melanocytic hyperplasia. The lentigo, as I just said, it's an overabundance of hyperactive melanocytes. There's no nest of melanocytes or pre-melanocytes. It's just a group of them. And it's super common. It's just Melanonychia. It looks the same. You can't tell this from just melanocyte activation without really a biopsy. And you get a line of, you get a line, just like you do the other conditions. The nevi, that's a mole, or a nevus is singular. And yeah, it's typically a junctional type of a nevus that occurs. And this one you get real nests of activated melanocytes or precursor melanocytes just with a mole called melanoblasts. It should probably be melanoblasts right there. But just like a mole, they're not fully mature melanocytes. They're these little mutated melanoblasts. And yeah, these are more common in children. The lentiginous lesions are more common in adults. If a kid has one of these, it's probably a nevus. It's probably a mole in his matrix causing this thing. Right? And then, needless to say, if you have too many melanocytes, they're going to be, and these melanocytes are awake, so they're injecting the anechocytes with pigment when they shouldn't be. And that's why you used to get these lines in your nails. Now, the bad one, the malignant melanocytic hyperplasia, aka subungual melanoma, these are no good. So the matrix melanocytes have mutated and become dysplastic. They very quickly turn into full-blown cancer once they detach. And this type of melanoma is very good at getting through the tunica media, the tunics of a blood vessel, and they can get into the blood quite easily. They love to metastasize. This is the type that took Bob Marley's life. It's a nasty one. They typically occur on, his was the great toe, but they can occur on the index finger and the thumb. Right? Typically strikes older people though, in the 7th decade of life, in your 60s. Caucasians not so much. Native Americans get hit with this subungual melanoma. 33% of them are affected by this. Latinos, African Americans, Japanese, Chinese, 17%. And this has nothing to do with the sun. This is, your toes are usually covered by shoes, so this is not a sun-induced thing. There's some rules about when you become worried. So if you see a line in your nail, if it develops when you're 40 to 60, raises an eyebrow. If you're African American or Native American or Asian, raises an eyebrow. Not too much eyebrows yet, but when the breadth or the thickness gets greater than 3 millimeters, then you start getting worried. I always, when I get these questions online, if that looks thick to me, I always recommend they see a dermatologist for that, because they're normally much thinner. 3 millimeters is fairly thick. That's bigger than the tip of a Crayola crayon. And if there's a changing, if the patient says, you know what, this used to be a thin, it's gotten wider and wider and wider, that's not a good sign. And heaven forbid if it extends up into the proximal nail fold, which we already saw a picture of, that's a Hutchinson sign. That's a very strong indication that it is melanoma. So that needs to be, this is probably the worst sign of all of them. Then a family history, if one of your relatives has subungual melanoma, then you're worried about it. Hutchinson sign, right? Look at that. Yeah, this is not This is no good. They got to see the dermatologist. They may lose their finger on this. But yeah, so when you get a discoloration of the proximal nail fold, no good. And the nails, these cells are mutated. They don't even work good. See how they're brittle and they're breaking. And yeah, that's no good. That's definitely no good. This person waited way too long. That's all cancer. That you're going to amputate the toe. And hopefully it hasn't spread up into the inguinal lymph nodes yet. They'll be doing a biopsy of those nodes to see. Some other ones, people waited way too long. These are all subungual melanomas. Yep, more bad signs. Variegation. If yours is variegated, that's not a good sign. Got to see the dermatologist. Again, if it increases in breadth or width, not a good sign. Variegated. There's a variegated one. See how it's different colors? That's no good. That's melanoma. And to make things worse, as you kind of zoom in, you see she's got a Hutchinson sign going on here. So that's subungual melanoma. Variegated. Really too wide. It's even in the finger on this side, it looks like, too. So, no good. Subungual melanoma. What's the treatment? Treatment's no good. Well, it depends what it is. If it's just functional melanonychia or benign melanocytic hyperplasia from a mole or from a lentigo lesion, you don't need to do anything. Now, if it's related to some disease, of course, you need to treat the underlying disease if possible. If it's some pregnancy, you don't need to do anything either. It'll pass once you have the baby. But if it's melanoma, if they have a Hutchinson sign and they biopsy it and it's cancer cells, it's treated very aggressively. This is a melanoma, as we've talked about. It's a killer. Gets in your blood system and flies over to your lungs and grows there and grows in your brain. And they'll usually take the toe right off. They'll amputate it, and then they'll check lymph nodes in the area, and if those have been affected, you might need radiation and chemotherapy. All right, thanks for watching. See y'all next week. Good job on that midterm, by the way. You guys did, most of you did very, very well on that. I was very happy with that. See you later.